The eye is one of the most vulnerable sites for the pathological impact of diabetes mellitus because of its unique anatomical structures and functions, but also because it is highly dependent on glucose for its metabolism. The pathophysiology of diabetes mellitus is characterized by chronic hyperglycemia, which results in microangiopathy and neuropathy. That is, damage to the smallest blood vessels and the nerves throughout the body, including the eye. Indeed, diabetes mellitus is the leading cause of blindness worldwide. And in this video, we will discuss the major ocular surface and systemic complications of diabetes mellitus. So let's get started. By far the most common complication of diabetes is diabetic retinopathy, occurring in 10 to 20% of all patients with diabetes, which makes it the leading cause of vision loss in working-age adults. It occurs due to the damaging effect of high blood sugar on the small blood vessels of the retina. The retina has a rich vascular supply from two sources, the central retinal artery and vein, which arise from the internal carotid artery, and the posterior hyaloid artery, which supplies the nerve fiber layer and the vitreous body. The small blood vessels of the retina are particularly susceptible to damage from hyperglycemia. This results initially in the formation of microaneurysms, which are small balloon-like bulges in the vessel walls. These may rupture and cause intraretinal or vitreous hemorrhages. Also, the blood-retinal barrier becomes leaky and allows fluid to enter the retina. This causes macular edema, which causes the macula to thicken and swell. In the later stages, the retina becomes ischemic. As a result, the body attempts to compensate by growing new blood vessels. However, these new vessels are fragile and leaky. They grow under the retina and in the vitreous cavity. Eventually, they become so severe that they cause vitreous hemorrhage and tractional retinal detachment. This is known as proliferative diabetic retinopathy. If the patient is fortunate enough to survive the initial insult, the retina may heal in place. However, this is not without complications. The newly formed vessels extend into the vitreous cavity and attach to the retina. This creates areas of scarring called glial adhesions, which distort the normally clear vitreous gel. The glial adhesions contract and pull the retina out of place, causing what is known as a lattice retinal detachment. The patient now has permanent blind areas in their visual field. However, if the retinal break persists, the fluid and cells in the subretinal space leak into the outer retina, causing permanent loss of central vision. Diabetic retinopathy can also present as diabetic macular edema, where fluid accumulates in the macula. Although DME can occur at any stage of diabetic retinopathy, it is a major cause of vision loss, especially in the early non-proliferative stages. DME is caused by increased permeability of the retinal capillaries and is often associated with cystoid macular edema, which is characterized by the presence of multiple small cysts within the macula. The next most common complication of diabetes mellitus is cataract formation. Normally, the crystalline lens of the eye is clear because it is highly ordered and compact. However, in diabetes, excess glucose in the aqueous humor is absorbed by the lens and then converted to sorbitol via the polyol pathway. Sorbitol is an alcohol sugar that cannot pass through cell membranes. Thus, when it accumulates inside the lens fibers, it causes osmotic changes, cellular swelling and damage, denaturation of proteins and lipids, and ultimately the formation of cloudy lens proteins. This is the process by which cataracts form. Cataracts occur earlier and progress much faster in people who have diabetes than those without. Less common, but still important, complications of diabetes include neovascular glaucoma, which is a severe secondary glaucoma caused by retinal ischemia in proliferative diabetic retinopathy. Abnormal blood vessels grow on the iris. These vessels expand into the anterior chamber and over the eye's drainage angle, leading to a rapid and painful increase in intraocular pressure. This can cause severe vision loss or even blindness if left untreated. Diabetes mellitus can also cause cranial nerve palsies. For example, it can affect cranial nerves 3, 4, and 6, which control eye movements. This causes eye misalignment known as strabismus or double vision, known as diplopia. Furthermore, diabetes can cause abnormalities of the cornea. For example, it can lead to persistent epithelial defects, neurotrophic keratopathy, that is, a decreased sensation of the cornea, and an increased risk of infections of the cornea. This is due to impaired nerve function and healing. Diabetes can also cause optic neuropathy, although it is less common than diabetic retinopathy. Damage to the optic nerve from diabetes causes a loss of nerve fibers and contributes to vision loss. In conclusion, as we have seen, diabetes mellitus has a significant impact on the eye. The most common complication is diabetic retinopathy, which can lead to vision loss if not managed properly. Cataracts are also very common in people with diabetes. Less common but serious complications include neovascular glaucoma, cranial nerve palsies, and corneal abnormalities. To prevent these complications, it is essential to maintain good glycemic control. In addition, people with diabetes should have regular comprehensive dilated eye examinations to detect any early signs of these conditions. Early detection and treatment of diabetic retinopathy is crucial to prevent vision loss. Fortunately, there are treatments available that can help slow or prevent the progression of diabetic retinopathy, such as panretinal photocoagulation, laser photocoagulation, vitrectomy surgery, and intravitreal injections. Thank you for watching. Subscribe for more medical education videos and leave your comments below. We'll see you next time.